Good evening, all the aspirants present here. It's the first session of our Brain Death and Organ Donation (CCS) session, and the speaker that we have here is Dr. Shraddha Patharkar. She is an associate consultant at ABMH Pune. Thank you, ma'am. You can continue.
Yeah, sorry for the delay. And per se, this is not just the organ donation topic. Uh, the cases will go through different vignettes, and then finally, I'll be talking about organ donation. So, am I audible?
Yes, ma'am, you are
Yeah,
audible.
okay.
All the
Yeah,
aspirants, it's going to be an interactive session, so you can unmute your mic, or if you have any doubts or anything, you can also share it in the chat box. Thank you, ma'am.
yeah. So, we'll start with the case. 30-year-old male, alleged history of road traffic accident. Motorcycle collided with the speedy four-wheeler coming from the opposite side. He became unconscious at the site of injury. On arrival of trauma response team, his GCS was E2M4VT, that is 8 by 15, heart rate of 130 per minute, BP was 180 by 100, saturation 92% on 15 liters NRBM. IV access was taken and the fluid resuscitation was started. The team was well versed with managing airway, so they intubated this patient with man in line stabilization of the cervical spine, and he was brought to EMS. Here, the patient's vitals got worsened. Heart rate dropped to 100 per minute. BP was 90 by 50. So NORAD was started to keep MAP of more than 80, and he needs high oxygenation ventilatory requirements also on the ventilator. So, can anybody enumerate what are the problems? What was the initial situation, and what is the reason for his hypoxemia and shock in this case?
Hello, ma'am.
Anybody?
Myself, Dr.
Yes.
Pankaj.
Okay.
So, a 30-year-old man came across a road traffic accident, having a uh, having an injury, became unconscious, uh, and
No, can you just tell
his
me the
GCS dropped
important
to
findings in
8.
this case?
Uh, Sorry, ma'am.
Just tell me the concerning points in this case. Young male, that is also an important point. Dangerous mechanism, mode of injury. So because he had a collision with four wheeler, speedy four wheeler. So just tell me highlight the important points. Like young male is there, dangerous mechanism, mode of injury is there, low GCS at from the beginning. It's 8. So just tell me the salient important points in this case. Other important points being
In his poor
hypoxemia.
GCS, ma'am,
Yes. And
hypoxemia
uh,
requirement. Then further he deteriorated, became hypotensive.
yes. So both hypoxemia and
Most probably the
hypotension.
shock, both, ma'am. Most probably the reason of shock would be
Yes. But there might be another reasons until proven otherwise. When in patient, it looks like polytrauma patient coming with hypotension. Probably the reason is hemorrhagic shock, but we need to rule out other shocks also. So you need to utter other things also.
patient can go into cardiogenic shock also due to Takasubo syndrome.
Okay, but tell me the commonest things first, no? Because he's hypoxemic, hypotensive, shock,
Can have
and first
can
you
have
have to
ma'am
rule out.
tamponade, can have cardiac
Yes, very
tamponade
good.
also.
Yes. You have to rule out
Then
It
obstructive
also
shock.
have the
pneumothorax,
neurogenic shock.
pneumothorax, tension
Tension
pneumothorax.
pneumonia.
Yes. So first you should utter obstructive shock like tension pneumothorax, pericardial tamponade, that you need to rule out. If that is ruled out, then hemorrhagic shock is the commonest possibility. Another being because we don't know about the spine, he was unconscious. So it might be neurogenic shock related to spine or neurogenic shock because of the brain also. That we'll see how. But because due to brain, initially he had a hypertensive response, so might be that time because of the severe neurogenic injury, he might later on had a stunned myocardium. So neurogenic stunned myocardium or stress cardiomyopathy, cardiogenic shock, any cardiac injury, because it looks like a polytrauma case. So you need to utter all these shocks. The common one
What
being
about septic shock?
no, I mean this is the first hour of injury, so septic shock might not develop in such a short time period. So you should not utter septic shock, but you can say distributive shock. So even your neurogenic shock is a distributive shock. Or whenever there is a severe SIRS response, then also because of the severe traumatic brain injury, there will be release of lot of catecholamines and cytokines that can cause distributive shock also. But here the commonest being obstructive, hemorrhagic, cardiogenic. You need to utter all these shocks. And reasons for hypoxemia.
Okay, there are quite a
Ma'am,
number of reasons
fracture of
why this
rib,
patient will be hypoxemic. Number one, because
laceration
of
of lung,
the depressed consciousness, he may have
then
airway obstruction. So
Yes,
airway
obstruction,
obstruction
then
is a
aspiration.
possibility. Then it may also be as a result of it may be apparent because of the hypotension. The SpO2 may be low because of hypotension.
Yeah, but
That's
the
it.
commonest being first you have to rule out lung related things. So
Okay.
yes, poor GCS can cause loss of airway and aspiration. Another
Yeah.
thing is commonest being if lungs are like there is a pneumothorax, tension pneumothorax, lung contusions. Because of that also airway injury. So those also these might be the reasons for hypoxemia, and severe shock also can cause hypoxemia. So he got
one
intubated at the
one
site.
more reason, ma'am. After fluid
Yeah, tell me.
resuscitation, patient can land up into fluid.
Yeah, but again, this is the like golden hour. Like first, it's immediately after the initial insult, he was shifted. So all these things will come later on. So what immediately you are suspecting is what I was uttered just now. So you need to intubate such patients with low GCS less than 8, those who are not able to handle their airway or there is an injury to the airway. Uh, uh, when despite patient here, one more important thing is despite patient being on NRBM, saturation is 92%. If uh, the patient is saturating less than 90% after giving supplemental oxygen, even if he is maintaining airway, it's better to intubate if he's not maintaining oxygenation, because secondary brain damage is equally important to save the patient, to avoid this secondary brain damage that you can avoid by maintaining oxygenation as well as maintaining blood pressure. It's very important. So then how will you proceed with this case? Once patient is in ER, intubated, so started on NORAD. Wha- can you tell me what you do in all trauma cases? How you'll start? How will you manage such cases? So you have to utter A, B, C, D. Can you tell me a primary and secondary survey?
I mean, we have to do the primary survey, ma'am, where we look for airway breathing and circulation, and uh, we have already protected the airway and controlled the bleeding, supporting the circulation. Look for any disability. The patient is unconscious, and we have to expose the patient to look for any toxin or any in major injuries to rule out. And then after the stabilization of the patient, once the airway has been protected, the circulation has been established, then we will go for head to toe secondary survey.
Yeah, but you see, for EDIC exams and even for managing patients, you have to be very you need to read the guidelines and you need to be very particular about certain things. Like when you are uttering airway, you have to say cervical spine stabilization, airway with cervical spine stabilization or
Yeah,
cervical spine
ma'am. Yeah,
protective
ma'am.
measures. When you are uttering breathing,
Since
you have to tell whether if the patient has a labored or obstructed breathing because of let's say pneumothorax or tension pneumothorax. So you might need to do decompression thoracotomy. When circulation, you have to utter hemostasis. You have to start with the fluids, but again in polytrauma cases we don't overdo it. In British trauma guidelines, they are trauma guidelines. They have mentioned you resuscitate only with 1 liter of crystalloids, uh, because in polytrauma you accept permissive hypotension till the time of hemostasis. So airway with cervical spine protection, ventilation, SOS, decompression if there is a tension pneumothorax, circulation with hemostasis, disability, and environmental exposure means then taking care of hypothermia and other stuff. So you have to utter these things. It's very important. And again in circulation, when it is associated with the TBI, then permissive hypotension should not be your management, because secondary brain injury, avoiding secondary brain injury is equally important. So already the primary injury has happened. You have to limit the primary injury and you have to avoid the secondary injury. So what are the primary adjuncts, primary survey adjuncts? So just managing ABCD is not like definitely it is important. Along with that, you have to do certain things to immediately come to conclusion. I have already mentioned on my slide.
Okay, let me add something. I'll rather put it this way, that during primary survey, we look directly for potential life-threatening events. Just like you had mentioned, look for signs of airway obstruction and respiratory difficulty as may occur from tension pneumothorax and cardiac tamponade. And then look for bleeding, bleeding into the like hemothorax and
No,
pneumothorax.
you have to utter in A B C D E fashion. You have to do that.
Okay.
So you have to utter primary survey. In primary survey, again primary adjuncts. Primary adjuncts means if you are suspecting tension pneumothorax, you'll quickly ask for X-ray. You'll immediately do bedside EFAS. That is also part of primary survey. It's a primary survey adjunct, because these have it rules out your shocks and helps you manage your case further. So you have to immediately go for EFAS, because patient is hemodynamically unstable, not able, you're not able to shift him to CT room. So better to do bedside EFAS to know whether he is bleeding or whether there is a tamponade, whether there is a tension pneumothorax, or there is a neurogenic pulmonary edema. So in my first slide, when patient had a hypertensive response, when there is a severe traumatic brain injury, there is this catecholamine and sympathetic surge that leads to sudden release of this catecholamines, leads to increase in afterload, and then patient might develop neurogenic pulmonary edema. And that's why in initial part, despite this hypertension, there was no hypotension but hypertension and desaturation. So these all things might occur simultaneously. So EFAST you have to utter. And can you read this ABG? What is the abnormality?
Ma'am, slide is not moving.
No, so this is the ABG and E. Can you read this ABG? ABG, it's, I mean, these two lines are there, no, on the slide. Can you see this ABG?
No, we can't see any
Mom, the
ABG
slide is stuck
results.
in slide 1.
But I am able to move this. So yeah. So now is it visible?
Yeah, now
Yeah. Yeah.
Yeah. Can you tell me what is? Can you read ABG? Anybody? So ABG was showing pH of 7.22, PaCO2 of 60, bicarb of 18.
Okay, it shows both
Oxygenation
respiratory
is
and metabolic acidosis.
which acidosis?
Both respiratory and metabolic.
Yes, yes. And
Um,
there is hypoxemia also. The PO2 of 100 with ventilatory settings, PRVC is 60% and PEEP of 8. So on transport ventilator, patient got shifted. He was so the oxygenation is also hampered. There is hypoxemia. There is both type 1, type 2 respiratory failure and metabolic acidosis because base excess is also -6, and the lactates all also raised. Even the base excess now it has a very significant it has significance in hemorrhagic shock because in uh, this British Thoracic Society classification of hemorrhagic shock, we have 4 grades. In that they have incorporated base excess. So you need to know all these things. So ABG was showing both mixed acidosis, and that mixed acidosis can be because of both the hypoventilation, this pneumothorax, lung contusions, or low GCS related CO2 retention, and bicarb was less or base excess was high. Maybe it is because of hemorrhagic shock, hypovolemic shock. And when the E-fast was done, this is the finding. Can anybody tell me what the left-sided image and the right-sided image show? Can you see the slide?
No.
Not yet.
Yeah. So can you tell me what are the ultrasound lung focus findings? So the left-sided ultrasound, can you make out what are the organs, what are
Ma'am, we
the
don't see
structures?
any image on this because
Is it
Ma'am, your
visible now?
slide is not visible. No, ma'am. Ma'am, your presentation is not on PPT, means sliding mode. You can
Yeah,
make it
I
on
have
slide mode
put
and then.
it on the sliding. I don't know. This last time also the same problem was there. I am putting it on the slideshow mode only. So can you see these slides now?
Not yet, ma.
Not yet.
Yes.
No, ma'am.
It's slide 2 that is still on display, the ABG.
So can you like maybe I'll zoom it out and can you make out now? Yeah. So actually, on my screen, I'm able to see all the slides,
Now it's visible,
and I'm
ma'am.
sharing the same slide. Okay. So all this while you were not able to see slides or what? Okay, fine. We'll go ahead with the case. Can you see this X-ray, chest X-ray?
We are on the focus slide.
Yeah, but can you see this X-ray? ABG and
The X-ray in slide 2 is not displayed, but we can see it from the.
I'm not able to understand what is happening. But can you make out at least? Can you is this X-ray visible to everyone? Chest X-ray.
Yeah, there is opacity on left side, ma'am.
Can you move to slide 2 because it is slide 3, the ultrasound, the focus that is currently being displayed. If you move to slide 2, we'll be able to look at the chest X-ray more closely.
Actually. Yeah, this is my first slide. Can you see this slide? Case first vignette. Students, can you see the first slide?
No, ma'am.
This is my case.
No, is the third slide that is on display right now, which is the ultrasound, the chest ultrasound, as well as the echo. That slide 1 is now displayed. Aha. Okay, this is the chest X-ray.
Okay, then I will not show in slideshow, because in slideshow you are not able to look at this now. We'll go with this only.
Okay.
Can anybody tell me about this X-ray?
Lung contusion.
Yes, it might be lung contusions, but bilaterally infiltrates are there, so you have to give differentials.
It's possible this patient also has RDS because the infiltrations are bilateral, and
Yes.
fairly uniform, woolly, mottled, diffuse opacities.
Some
Yes.
pulmonary edema, lung contusion,
Yes. Yeah, okay.
pneumothorax, and
Uh,
then
it doesn't pneumothorax. It doesn't look like a
pneumothorax.
pneumothorax
No,
because it might
pneumothorax.
be
I said
pneumothorax because
pneumothorax.
yes, yes, because the CP angle is blunt on the left side, and there is crowding of ribs, so there is a collapse also. But there are no rib fractures that are visible. But bilateral infiltrates, this pulmonary edema can occur within few hours or within few minutes also. I've told you about this neurogenic stunt
Neurogenic
myocardium
pulmonary.
or neurogenic pulmonary edema. It is also it's because of this catecholamine release or surge. So, can you differentiate between neurogenic pulmonary edema and cardiogenic pulmonary edema? Neurogenic pulmonary edema behaves like ARDS only, but what are the differences? Like, because the management is totally different. So, the neurogenic pulmonary edema is because of the catecholamine surge, and that causes increase in a blood pressure. As in in first slide, the BP was high immediately after the injury. So high BP increases the afterload, LV afterload, and because of this increase in LV afterload and pulmonary capillary wedge pressure, it's the mechanism looks similar to cardiogenic pulmonary edema, hydrostatic pressure, but at the same time there is also endothelial injury. So leaky capillaries, which is the mechanism of ARDS lung. Both mechanisms, we call it as a burst theory. So both things can happen in this. The only problem here, it is not the volume overload. Rather, these will be volume depleted. This polytrauma patients with blood loss and hemorrhage. So giving diuretics is not a good choice. Rather, it will worsen your case or situation. Putting patient on ventilator, ruling out pneumothorax, and increasing PEEP might help. If there is a hypertensive response, again, for cardiogenic pulmonary edema, you can give NTG, but again, giving NTG in this case is detrimental. You you have to use other antihypertensives like nicardipine and all. But in our case, later on, patient had shock also. So again, this is not the choice. But you have to keep this in mind. Neurogenic pulmonary edema, diuretics you should not choose as opposed to cardiogenic pulmonary edema. And also NTG is not preferred if there is a hypertensive failure or hypertensive response. So, and even the stress cardiomyopathy, and that can precipitate this pulmonary edema. But again, in our treatment in such cases where there is a tachycardia and hypertensive response, then giving antihypertensive beta blockers might help. But again, it's very tricky when you have not ruled out shock. Don't give all these things. So, and the difference between myocardial infarction related pulmonary edema and stress cardiomyopathy related or neurogenic stunt myocardium is your NT-proBNP will be quite higher than TROP-T or TROP-I. In when it is MI related pulmonary edema, TROP-T, TROP-I will be high. There will be reciprocal changes. But here, even if you will get ST elevation on the ECG or T wave inversions, there will not be any reciprocal changes, and even the tropi elevation won't be that significant, but NT-proBNP will be quite high. So these are the little changes, the differences between different scenarios. So can you now read this ultrasound? So one is lung focus and other is 4-chamber cardiac apical view.
Fluid in Morrison's pouch.
Only in Morrison's pouch. And like whether it is left-sided or right-sided, where is the fluid? On X-ray also, we have seen more opacity and haziness towards left side. So you have to correlate and
The fluid in the splenorenal space.
yes, and because you can see even during my EDIC exams, we got this slide where you have to make out where the diaphragm is and whether the fluid is above the diaphragm and below the diaphragm. Because above the diaphragm means it is in the pleural space. Below the diaphragm means it's in the peritoneum. So where is this fluid? There is a.
So it's like there's above the liver, so in the
Very good. It's the free fluid is there on both the sides, above also, and you can make out the jellyfish lung, and there is the hyper intensity of the collapsed lung, and some contusion also you can see. And below the diaphragm also there is some fluid around the spleen. So it's hemoperitoneum as well as the hemothorax. And in apical 4-chamber, is there any pericardial effusion or anything? What is there on the left side of the heart? You need to know the different views of the focus. So here in apical 4-chamber, the left side of the heart will definitely, it will show the left side of the lung and the left-sided lung structures and fluid. So that is a collapsed left lung in the left pleural collection, and probably it is the hemothorax. Being polytrauma case, it looks like a left-sided moderate to severe hemothorax with the collapsed lung. Can you make out, students? Yeah. So because they will definitely in polytrauma cases they will give you some focus images. So again, with this X-ray and with this EFAST positive, how you will manage this case? Patient is in shock on NORAD, your EFAST is positive. If you are considering this as a hemorrhagic shock, you have done the primary survey, you have done primary adjuncts, and now you have in primary adjuncts you have found out the cause for his shock. Now what you'll do?
Okay, we prepare blood or activated massive blood transfusion protocol. We'll insert chest tube in the left side for his hemothorax, and we'll call surgery to enter operative room for laparotomy, exploration laparotomy.
Yes, very good. And when you are managing, you have to tell them, I will send all the routine labs with coagulogram. I will maintain, I will try to correct his acidosis. I will correct his hypothermia. These things, whenever polytrauma case, hemorrhagic shock, you have to utter all these things. Yeah, I will do sequential ABGs to see whether to my fluids, his lactates and base X's, these are things are responding or not. So because if there is a type 1, type 2 shock, your crystalloids will help. But once the patient is in type 3, type 4, the choice of fluid will be blood. And according to again this ATLS and protocol, your after 1 liter of crystalloids, for the shock, you need to give blood. You cannot keep on giving crystalloids because it will worsen your coagulopathy, dilutional coagulopathy that might develop later on. So yes, the patient is in shock, your E-fast is positive, there is a massive hemothorax also, and patient is having high ventilatory requirement. So you have to put ICD for this patient. You have to again, if what are the indications of thoracotomy, if at all, this patient, because again, if you'll not drain this, I mean, you will put, you have, let's say you have put ICD, and what are the criteria that will suggest you to do thoracotomy? You have rightly you have said you have immediately involved surgeon also in this. So now you have, as an intensivist, you have put the ICD, and what are the criteria that you might need thoracotomy?
Ma'am, fluid selection of more than 1 liter after putting of ICD, or more than 300 ml after 1 hour of ICD.
Uh, so there are certain numbers that you need to like uh, know that by heart. Like if after putting ICD, 1500 ml is drained immediately after putting ICD, or if it is draining almost 250 ml per hour for the consecutively 3 hours. If all these things are there, then you have to definitely do thoracotomy. So these criteria you need to know these numbers, and there are certain scores like ABC score, TASH score. So these are the scores that indicate the need for the massive blood transfusion. Now here the patient is bleeding, maybe in this ABG, if the HB is low, by the time labs have come and the HB is 5, then also you can activate your massive blood transfusion protocol. Otherwise, there are certain scores also that indicate that you need to activate this massive blood transfusion protocol. So you need to know certain scores like ABC score, your shock index. What is shock index? It's systolic BP divided by heart rate. So this is also very important indicator that patient is might be actively bleeding. And when you call it massive blood loss, how many
Ma'am,
PRBCs?
requirement of 10
Uh,
unit of PRBC in 24 hours, or 4 unit of
okay,
PRBC in 1 hour, or
okay,
50%
and
of.
yes, yes. So if all these things again, the various scores or whenever these criteria are getting fulfilled of massive blood loss definition, you have to activate massive blood transfusion protocol. So again, in trauma cases, this coagulogram like APTT, INR, and fibrinogen and all these things, though there are no trials which have shown the thromboelastogram or rotem are better over your conventional coagulogram parameters, but the mechanism of trauma-induced coagulopathy is different as compared to your other coagulopathies. Here, there are various phases of coagulopathy that happen. Can anybody tell me what is trauma-induced coagulopathy? How it is different from other coagulopathies? What is predominant phase? What we give in initial 8 hours, immediately and within first 8 hours?
Ma'am, there is consumption coagulopathy, means, and second is dilutional coagulopathy. Both are the reason.
Yes. Though in first 1 or 2 hours, there will be secondary hyperfibrinolysis, because there will be consumptive coagulopathy. There will be excess of hemostasis. That is because it's a severe trauma is such a inflammatory response. There will be a lot of endothelial damage, and there will be body tries to achieve hemostasis. For that, there will be a lot of consumption of blood products, and there will be secondary hyperfibrinolysis. So even the hyperfibrinolysis starts even before the initial steps of clot formation and all. So it might be that severe. That's why tranexamic acid has a very important role. So you need to know crash 2, crash 3 trials for that. So crash 2 is for polytrauma and crash 3 for traumatic brain injury. Giving tranexamic acid 1 gram stat and then 1 gram within 8 hours. Giving it later on, it's detrimental, because in initial phase there is a hyperfibrinolysis. In middle phase there will be coagulational dilutional coagulopathy, because you have given 1 liter of crystalloids. Maybe you have just started PRBCs, uh, uh, considering that hemorrhagic shock is there, but then there is a clotting factor dilution effect, platelet dilution, and that induces coagulopathy. And in later on there will be hypercoagulable state. So all this you cannot make out with your conventional coagulogram. So in this case also, this ROTEM was ordered. And by the time labs have come, can you see this slide?
Yeah, ma'am.
Students, can you? Yeah. So the labs now suggestive of HP of 5.5, platelet 70,000, INR, fibrinogen, LFTs are still awaited. And this is the ROTEM. We have already discussed massive blood transfusion protocol. Now, can anybody tell me what is a lethal triad? Trauma lethal triad?
Hypocoagulability, metabolic acidosis, hypothermia.
Yes. So just correcting giving blood products might not help. You have to correct these other things also, equally important. Even correcting calcium, because all these clotting factors to work, you need adequate amount of calcium. So, what are the hematological targets in traumatic brain injury? Like for cardiac cases, we try to keep hemoglobin 9. So what are the, like, there are some retrospective studies data. They suggest maintaining HB of 7 to 9 is important in TBI cases. And for rest of the polytrauma cases, how should be, I mean, to avoid excessive blood loss, what is your target for platelets? What is the target for fibrinogen? For TBI, you need to have a little higher target than that. But for routine trauma cases, you need to keep platelets more than 50,000 and fibrinogen more than around 150 milligram per dl, for 150 to 200. For TBI cases, your platelet should be more than 1 lakh, and this fibrinogen more than 200. So please read this ATLS and brain trauma guidelines, because there are very straightforward numbers. You don't need to remember it. And again, I have forgotten one important point in our previous discussion. Maintaining saturation more than 90% is needed in to avoid secondary brain damage. Equally important is the blood pressure target. Can anybody tell me what are the systolic blood pressure targets in their age wise targets they have mentioned in the guidelines, in 2020 guidelines? Can anybody tell me the targets for blood pressure? Can you hear me?
Yeah, ma'am.
Yeah.
If age is less than 40 years, then we have to maintain a systolic blood pressure of 100. Am I right?
No, there are like,
I'm not
see,
confused.
again, I'm telling you, please go through guidelines. There are like reasons for all those numbers. You cannot randomly utter these numbers. When the age is 15 to 49 or more than 70, 15 to 49, because here the young patient, the brain is not atrophic. So when there is a raised ICP, there is hardly any space to expand. So whenever the ICP rises, we know that cerebral perfusion pressure is MAP minus ICP. So whenever ICP is increasing, to maintain CPP, your blood pressure target should be high. So that's why when the age is between 15 to 49, you need to have a systolic blood pressure target of 110. And when the age is beyond 70, here the brain is atrophic. But these patients are probably with, by this age, so many comorbidities, hypertensive. So autoregulation is set at a little higher level. So in them also, you need to keep blood pressure on a systolic BP more than 110. And the age group between 50 to 69, there you can keep systolic BP 100. So it's very important. All these are very they have mentioned in everywhere in all the guidelines. You have to read it. And another thing is uh, we have talked. We have yes, this permissive hypotension. So permissive hypotension is advisable in polytrauma cases, but not in TBI, because hypotension causes more damage to brain by both reducing the cerebral blood flow as well as by decreasing the O2 supply to the brain, because brain depends on the oxygen and glucose. It doesn't have all the stores, and that come from your blood supply. So maintaining good perfusion is very important, and that's why permissive hypotension means keeping systolic BP 80 to 90 till the hemostasis is achieved. If brain is not involved, if there is a abdominal trauma, chest trauma, or maybe some limb long bone fractures and massive blood loss, in those cases before hemostasis is achieved, you have to keep lower blood pressure to avoid excessive blood loss, or to avoid that whatever the hemostatic plugs or clots they have formed, to get avoid dislodgement of those clots and uh, further bleeding. You have to accept the lower blood pressure just to perfuse your tissue level. So for all those trauma patients, keeping again these targets are very important. Keeping systolic BP 80 to 90 or a map of 50 to 60 is acceptable, but when brain is involved, you have to keep map of 80. There you cannot compromise on keeping lower blood pressures. This is very you need to get it clear, these all these targets. So here we have discussed about hematological target as well as the macro circulatory like BP and saturation targets. Now can anybody interpret ROTEM? And because see, in EDIC exams, definitely in trauma case they will give you ROTEM. We are used to TEG, but in EDIC exams they are, because they use ROTEM on a daily basis for all, like whether it is liver cases, obstetric hemorrhage, or trauma. So you need to know this. I'll not go very much in details because it will take long. But can you interpret? You should know the what is the normal shape of this ROTEM. Then even by looking at shape, you can make out what is wrong. Can anybody read this ROTEM? Uh, see, here most important first foremost is you need to have extem and fiftem first, because in trauma here again we did not discuss this in massive blood transfusion protocol. When you activate that 1:1:1 transfusion is important to like we need to give all factors in proportion. If 4 PRBs, then giving 4 FFPs, giving 1 SDP, like that, or giving along with that giving 10 cryo. So it is the proportional, the proper trial is there. So they have mentioned 1:1:1 is better uh, outcome wise. So here again in ROTEM you can in trauma also fibrinogen and platelets, because why these thromboelastography or metry they are important, because they not only tell you about the clot formation but clot formation, propagation, as well as clot lysis. So all the steps will be covered. That's why where we are going wrong we can make out. So various mechanisms that are involved in trauma induced coagulopathy. So where to act, because in all this I have told already consumption coagulopathy, so fibrinogen levels, platelets level will drop because those will be consumed, and there will be initial phase mein hyperfibrinolysis. So we need to first focus on these three, and that's why first you need to look at the extem and fiftem. Extem is like your extrinsic pathway, intem for the intrinsic pathway, fiftem is your functional fibrinogen, and aptem is you can skip this. This will help you rule out the antifibrinolytic effect if the patient is on some antifibrinolytic. But at least you should know extem and fiftem. If and in that, it's better to you need to know certain values also, to understand it quickly. But if in XTEM you are A10 and in FIPTEM you are A10, what is that you need to look at? So first you look at the FIPTEM A10. If that is between your 8 to 25 it means it's in the normal range. And in XTEM A10, you can make out that it is more than 25 so that is normal. But in FIPTEM, it is 3 only. So that indicates there is a fibrinogen deficiency. Many a times in both XTEM and FIPTEM, your A10 will be low. So it might be both fibrinogen or it can be platelets also. But first you have to go by replacing fibrinogen and see whether that A10 in the FIPTEM is getting corrected. If that is getting corrected and still there is A10 is very low, then go for platelets. So first you have to rule out this fibrinogen deficiency, platelet deficiency. Even with after correcting those, if your CT or CFT, clot formation time, clotting time, they are high, then you can think of giving. If FIPTEM deficiency, then you can give fibrinogen concentrate or cryoprecipitate. If it's a platelet deficiency, then you go for SDP or RDP. If there is still there is a CT, CFT, those are prolonged, then you have to might go for 4-factor PCC or FFP. So and again, if there is a graph is showing hyperfibrinolysis, that is LY30 more than 8% or LY60 more than 15%, maximum lysis time, all these factors when you consider, and then you have to think about fibrinolysis. And another way, many times that APTEM is given because if your APTEM is because here they have used aprotinine. It is like tranexamic acid only. And if your clotting time is getting corrected using APTEM, then it indicates it's a hyperfibrinolysis. So I cannot explain this in this class, but you need to know the only thing right now you remember important is XTEM and FIPTEM first. First correct fibrinogen and platelets according to these two graphs, and later on think about other things. And you have to keep in mind hyperfibrinolysis also. So APTEM is also important. Uh, so yes, you have transfused this patient, and once his BP was okay, parameters got better. The whole body CT scan was done, and out of that, this is the neuro CT scan. Can anybody read? And again,
Not
EFAST
visible.
you have to keep on doing. Yeah. So our patient, actually in my case, our patient could have got shifted to OT as early as possible after activating the massive transfusion protocol. But after giving blood products, patient was okay, and EFAST showed no increase in bleed, and HB was also improving. If HB was still falling, then you have to go for damage control surgery, because maintaining uh, good hemostasis and maintaining good HB and maintaining good BP is more important for brain rather than operating that brain then and there. So if there is an active source of bleed, you have to go to OR. But in my case, EFAST was stable after transfusion. Blood parameters, everything got better. Even the BP got better. So the whole body CT scan was done, and out of the whole body, this is the brain cuts. Can anybody tell me first image, second image, and third image?
Ma'am,
The
your
bone
slide
window
is
and
not
the.
moving. Sorry, ma'am, your slide is not moving.
Okay. Can you see it now?
Now visible.
Yeah, it's the first CT scan shows a massive subdural hemorrhage, and then there is the midline shift, significant midline shift, and obliteration of the left ventricles, and of course, I think there is massive brain edema.
Hmm. Yes. So you have to utter this. Which side, that also you have to utter. It is massive. Which-sided subdural hematoma?
Left,
Yes. Left-sided
left
subdural
brain.
hematoma with
Yeah.
ipsilateral ventricle
With
compression,
midline shift
midline
to the
shift
right.
of
Uh-huh.
yes, and
And
the
there
mass
is,
effect in the form
yeah,
of
uh,
obliteration of sulci gyri, because there is a lot of cerebral edema also, and
yeah.
there is probably a subfalcian herniation also, because even that midline has got shifted. Yes, and the second brain window, axial cut second image.
Um,
This is a very important
it
area
again
where
shows
you can.
ossification of the left ventricles, and there's also the subdural hematoma.
Yes, it is
Subdural.
there, but in which area it is? This
Yeah.
is the
Okay. It's that's that should be said. The
temp.
left
Yes,
temple. The left
yes,
temple.
yes. So why you're worried? What is like? Uh, why you're worried about lot of edema and midline shift in this area? Because in first slide we have seen subfalcian herniation. That was the frontoparietal area. Here it is temporal region. There will be high chances of uncal herniation.
Okay.
In this, you need to know in which area what herniations, like transtentorial herniation, subfalcian. When there is a subfalcian herniation in our first slide, there is a ACA might get compressed because this compression effect, mass effect, and patient might develop this frontal parietal infarcts. Like in uncal herniation, there is oculomotor nerve compression and patient might develop unequal pupils. Patient might develop unresponsiveness.
Korea.
Yes, anisocoria, weakness, unresponsiveness. But anyways, our patient was is unresponsive from the beginning. But they do ask what is the significance. And in my third bone window, though it is like I have taken the wrong picture, it is on the there is a fracture seen on the right side, but actually pertaining to my case, it could have been on the left side. Which area there is a fracture? You need to know the basal skull uh, images and all the anatomical details also, just to make out what they might ask, what is the significance, what complications might happen. So in this is the petrous part of temporal bone. So there is a fracture, and again temporal area, there are two things that you need to worry about. Middle meningeal artery is there, so chances of EDH is common when there is a this fracture. Again, the petrous part temporal bone, CSF otorrhea might happen. And third is uncal herniation, because this temporal area, if there is a lot of edema, mass effect, so pertaining to these areas, you need to look for these things. And again, when this A, B, C, D, E, you are uttering, I'm not going into details of that because this is very common thing that all trauma patients you must be doing day in and day out. But you have to utter all this. In disability, you have to utter about pupils. So all these things are very important. But let's go ahead with the case. So, and what is the next step? Again, here there is a mass effect, there is a midline shift. So, what you will
Yeah,
do?
the next step is to reduce the intracranial pressure.
Yes,
There are quite some measures that will need to be adopted immediately, including mechanical ventilation, sedation, and muscle relaxation, and then head uplift, and then give osmotic agents like 3% saline, and prepare the theater for surgical intervention to evacuate the
yes.
hematoma and possibly decompress the skull.
Yes, very good. But you need to utter the three-tier system, like three-tier mechanism of reducing the ICP. Because here, if especially when there are impending signs of herniation, when there is a anisocoria, definitely you need to rush this patient to OT rather than going into various tier 1, tier 2, tier 3 management, because decompression cranectomy might occur in, if needed, even in tier 1 you can consider it, but otherwise you have to follow the tier 1, tier 2, tier 3 protocol of managing ICP. So here again I've taken this slide just to know, because they can show this slide here in the CT scan instead of the previous one SDH slide, because of the TBI. This is the CT scan which is hardly showing any much of an insult, just one or two punctate hemorrhages, and there is a sulcal gyri effacement, but it doesn't look that bad. But patient's neurological condition is very bad, so it's not correlating. Your imaging is not correlating with the clinical condition of the patient. In such cases, you have to think about the diffuse axonal injury, and
That's right.
yeah, then you have to go for MRI to grade it, how severe it is. And grading is important to know the prognosis of the patient. If it's a diffuse axonal grade 1 and 2, there are chances of reversibility, and patient might not develop significant cerebral edema and might not need decompression craniectomy. But if it's a grade 3 and 4, then there is a high chance. So they might give you this scenario: patient is clinically that bad, but imaging wise it doesn't look that bad. So possibility might be diffuse axonal injury. Again, can anybody tell me indications of ICP monitoring in trauma?
Once the severe elevation in ICP over more than 25 centimeters of water, there should be monitoring of intracranial
No, I
pressure.
mean, how come you'll understand whether it is 25? So,
If
what are the
age is
indications when
Okay.
you'll put ice?
Oh, okay.
if age is more than 40 with
Okay,
abnormal CT scan,
tell the common factors first. No, Matlab, if the GCS is less than 8
less
with
than 8
CT findings,
abnormal CT finding,
yes, abnormal CT
and
findings,
iso
whether it is SDH, EDH, intraparenchymal bleed, midline shift, cisternal compression, all these abnormal findings along with the poor. In our case, there is abnormal finding, and patient's GCS is also less than 8. So he is a candidate for ICP monitoring. Another being GCS is less than 8 with normal CT scan, provided that two or more factors are present. Which are those two or more factors? You rightly said age more than 40 years, bilateral or unilateral decerebrate
and
decorticate, anisocoria, yes. So when two or more of these is present, and third, in that three criteria, third one is systolic blood pressure less than 90, because we know that CPP is MAP minus ICP. So when your pressure BP is very low, there are chances that like uh, you might need to maintain higher CPP. For that also you need ICP monitoring. And other factors like anisocoria, uh, but anisocoria and all, you will anyways shift patient as early, because that is the last stage. Your brain cerebral autoregulation has gone. Brain is herniating now. So that is the last stage. There the operative management and other things will play a role. But what I have initially mentioned, all these are the ICP monitoring indicators. Uh, and can anybody enumerate invasive as well as non-invasive measures of ICP monitoring? We'll do it a little faster. There are many slides. Invasive measures are like, I've already told about this ICP monitoring.
Intraventricular
What are the various methods?
intraventricular
catheter.
intraparenchymal catheter.
Yes, subdural, epidural monitor, fiber optic transducer, and subarachnoid bolt. So again, you need to know the advantages, disadvantages. The advantage of intraventricular catheter or EVD is you can monitor ICP, you can drain CSF also if there is a uh, hydrocephalus, or when there is a increased pressure by reducing the CSF, Monroe-Coley doctrine, you are making space. So another other invasive measures being, I have some slides to show those invasive measures, because for CBS they will put those slides, and we have, like, not all hospitals have invasive ICP monitoring measures and methods. Very few will have. So this PBTO2 monitor. So that in the parenchymal oxygenation, brain oxygen tension monitor, PBTO2. Normally it should be 25 to 30, but if it is less than 20, there is like low perfusion to the brain. And if it is less than 15, it means like there is maybe irreversible damage might happen. So monitoring PBTO2 is very important, especially when you are hyperventilating the patient, because hyperventilating the patient to buy some time before shifting patient to the OT or doing definitive measures like putting EVD and all. If there are impending signs of herniation, so in because you are hyperventilating, there is CO2 washout, there will be cerebral vasoconstriction, and that will affect the O2 supply to the brain parenchyma. So you cannot keep on hyperventilating the patient without knowing what is the brain tissue oxygenation. Otherwise, you will cause more harm. So as I've said, there are like invasive monitors. Like, one of them is this PBTO2, another being jugular venous oximetry. So HGVO2, that tells you about the global oxygenation. Again, you put the catheter in a reverse way into the jugular bulb through your IGB. So that is also important. Again, normal value being 55 to 75%. So if there is a less, it means your ICP is quite high. Your venous drainage is not happening. Your PaCO2 is very low, that causes vasoconstriction. Your low blood pressure, increased O2 consumption because of fever, because of seizures. That's why fever is very detrimental in brain. If like maintaining hypothermia is not always needed, it's the tier 3 management, but you at least you should avoid fever. Even 1 or 2 episodes of fever can worsen your ICP and you might lose the case. So you have to be very aggressive about fever and even seizures, because that also causes secondary brain damage. That's why in trauma you give seizure prophylaxis, especially the acute like first 7 days. You need to give seizure prophylaxis. Again, phenytoin, levipil, these things are preferred. Then cerebral vasospasm, arterial hypoxia, all of these things will cause drop in your SjO2, venous jugular venous bulb oxygenation will decrease. And when it will be excess, when there is a reduced extraction of oxygen, it's like SCVO2 only. There are like the only certain brain related factors you need to remember. So whenever there is reduced extraction, the jugular venous oxygenation will be on a higher side. So maybe hypothermia, patient is on sedatives, excess of cerebral blood flow is there, maybe because of the vasodilatation. When PaCO2 is high, there will be vasodilatation. So arterial O2 content is high. So you need to know all these things, and even brain death patients, because when there is no brain activity, brain will not utilize anything, and there will be jugular venous oxygenation is nothing but the how much blood flow is there to the brain and how much it is utilized by the brain. Whatever is left over is your jugular venous oxygenation, similar to SCBO2. You need to know these other invasive, because in CBS they will keep these monitor pictures and they'll ask. Now I've uttered about this PBTO2. They will show this catheter and this subdural bolt through which they'll put this catheter in that area to measure the brain tissue oxygen. Again, less than 20 is not good. Less than 15 can cause irreversible brain damage. And they will show this picture of Lycox monitor with some numbers. So in that Lycox monitor, you can put PBTO2. That 26 is PBTO2. Again, 26 PBTO2 is normal. Oxygenation of the brain is normal, and O2 tension of the brain, and then temperature probe is there, and there is a ICP monitor. These three things are there in this Lycox. So they will definitely, as one of the spotters, you might get these. And now there are certain non-invasive measures. Again, in invasive intraventricular catheters, there is a high advantages. It's accurate. You can drain the CSF, but the disadvantage being infections and bleeding. For rest of the things, infections, bleeding risk is less, but accuracy is also less. So again, other non-invasive being optic nerve sheath diameter. You need to utter all these things in non-invasive methods of ICP monitoring, because it's very bedside, very handy. You can frequently reassess. How you measure 3 mm behind the optic nerve sheath. 0.3 centimeter means 3 mm. 3 mm behind the optic globe, and you have to include optic sheath also in it. The black color is optic nerve, and the white lining to this is the optic sheath. So it, there is this extension of a dura, and between this dura subarachnoid, uh, in the subarachnoid space between pia and subarachnoid, there will be CSF flowing. So whenever there is excess pressure, that CSF will be shifted into this subarachnoid space, and the size will expand. So you have to measure here, and if it is beyond 5 mm, then you can, because again there are no specific cutoffs. Some meta analysis say it is 5.2, but at least you can consider beyond 5 it is raised ICP. On either sides you need to check. So again, they'll show this diagram and they'll ask what is the management. So you have to see whether on the left side it is showing 0.53 centimeter, on right side it is 0.7. So again, it is indicating increased optic nerve sheath diameter. More than 5 mm indicates ICP is more than 22 mm of SG. So again, criteria. Another non-invasive method is your TCD, transcranial Doppler. I will not go into details. We'll see some part in brain death, but you need in again transcranial Doppler. You can make out midline shift. You can make out reduced cerebral blood flow, and there are some cerebral circulatory arrest patterns. You need to read all these things, because definitely in spotters also they will keep this. Another new thing is now this pupillometer. So rather than checking manually with torch, there are like this pupillometer can find out ICP quicker than your usual methods, because it will tell you about the reactivity also in percentage. So when there is a normal ICP, pupillary response to the light will be 35 to 36% decrease in the size. If that is reduced by 20%, it means not only the size, before the pupils become unequal or non-reactive, you can grade how brisk the reaction is, and accordingly you can take action. You might shift the patient earlier than patient becoming anisomoric or pupils non-reactive. So in that, again, this NPI score or QPI score is there. If it is 3 or higher, it is the normal pupillary response. Less than 3 is inactive or abnormal pupillary response, because these things many hospitals nowadays they are doing. That's why you need to know. And there is another monitor like NIRS. Again, these are all the non-invasive methods: pupillometer, optic nerve sheath, transcranial Doppler, NIRS. NRS also, it tells you the the pulse ox tells you about the saturation, your blood saturation, like that. In that way, this NRS, there are pads that is put on the forehead. This is the diagram. They might show what is this. They will ask what is this. Uh, this is the infrared, non-invasive infrared spectroscopy. It tells you about the brain oxygenation. So 60 to 70% is normal. So again, this is the invasive. PbTO2, SgVO2, this microdialysis catheter, they are invasive. So this microdialysis catheter, it tells you about the metabolic parameters in the brain. When there is a increase in lactates, in a decrease in glucose, increase in lactate pyruvate ratio, it all indicates there is some ischemia, some hypoperfusion. It might be because of raised ICP or any other causes. Glycerol, glutamate. So these are all multimodal neuroimage monitoring. Okay, so you have put the ICP catheter, and yeah, this is very important. This slide, the ICP monitoring. I have uttered about this three-tier system. You need to know tier 1, tier 2, tier 3. I will not go into details of the component, but you have to know this. This is very important. Keeping your head neutral, giving sedatives. Even EVD is your tier 1 therapy. Putting EVD, sedating patient to avoid cupping and bucking, targeting normothermia, head neutral, no avoiding C collars as far as possible. So that's why once the cervical spine is clear on the scan, it's better to remove that collar as early as possible to avoid your brain damage, secondary brain damage. Even managing thoracic abdominal pressures when there is abdominal compartment syndrome, you are overloading patient, when there is RV dysfunction, anything that increases the CVP, high P beyond 12, 14. So all these things also, because it reduces the venous drainage from the brain, and that's why it increases the ICP. So you need to know all these things. It's very important. And this map challenge is also very important, provided that you have ICP monitor in situ. So it is guided by ICP, the three-tier system. When uh, you have already ICP monitoring device in situ, so what you do is, this is also is one of the spotters they give you graphs. So normally when when ICP is raised, you know that Larson's curve, till one point of a time, your body has a capacity not to increase the pressure despite increase in the volume, till the auto regulation is there. Once that auto regulation is gone, even the small volume, or the when the compliance, brain compliance goes down, even the small volume increase in the smaller increase in a volume cause bigger change in the pressure, and ICP goes up suddenly. So this map challenge is to assess the cerebral auto regulation and to guide your map and the CPP targets. So again, in like I said, you have the map target, you have systolic BP target in traumatic brain injury. Another important target is CPP. You have to keep in brain trauma guidelines. They have mentioned keeping CPP 60 to 70 is important. But again, how you will come to know about CPP? Map minus ICP. For that, you need to have a ICP monitor. So performing map challenges to assess the cerebral auto regulation. So when you say that auto regulation is maintained by increasing the map, if your ICP is dropping, map minus ICP is CPP. By increasing map and by increasing CPP, your ICP is dropping. This means there is auto regulation that is intact, because you want ICP to drop. So when you do this map challenge, you increase it by vasopressor or giving fluid or inotrope. You increase map by 10, but not more than 20 minutes. And then you see the ICP number. If that is coming down, or the height of your ICP waveform is coming down, it means patient's auto regulation is intact. So keeping BP little on a higher side will help. But once the auto regulation is gone, your brain cerebral blood flow is becomes pressure dependent. More the map, more will be the cerebral blood flow, more will be cerebral blood volume, and it will harm the patient more. So they will in spotters they will show you this graph. So here you can see when the your BP is high, where CPP is high. Not this graph. So here see here once this when your BP is high, CPP is high, your ICP is going down, and when the BP is low, your ICP is increasing. So the basically to reduce ICP, if by increasing MAP or by increasing CPP, if your ICP is going down, this means cerebral autoregulation is maintained. But when increasing BP will increase ICP, it means the autoregulation is lost. So they will show, definitely they'll show you this one of the graphs in your CBS. So again, regarding these ICP waveforms, can anybody tell me all the three waves of the ICP? Can anybody tell me all P1, P2, P3? What are these waves? Is anyone there? Students?
Yes, ma'am.
Yeah. So P1 is because of
arterial pulsations
yes.
is because of
So
P1 decrease in
P1 is
arterial
because of
pulsation,
the arterial pulsation through choroid plexus. Yes.
and
P2 is because of
P2 because of the brain tissue compliance.
yes, but the same arterial pulse when get reflected from brain parenchyma, then it is a P2 wave.
P2, yeah. And then
And
dichrotic
P3
wave is P3.
yes,
Dichrotic venous.
there is a aortic valve closure, the arterial pulsation, it's like P3. So the whenever there is a hypertension, what will happen? If
P2
you
will
are
become higher than P1 in
no
elevated
when
ICP.
yeah, but when there is a hypertension, when there is a hypertensive response, BP is high,
Oh, okay.
your P1 will go up, height of P1 will go up
Okay.
because P1 tells you about the arterial pulsation through choroid plexus. It's the arterial blood flow. So your BP is high, the blood supply will be high in that blood will flow at a higher pressure, no? So P1 will be high, but P2, P3 will be normal. When there is a hypotension, your P1 will be low. So your arterial blood pressure related is P1. P2 is your compliance. P2, P3 will be always lesser than P1. But once the P2 becomes more than the P1, it indicates loss of compliance. When you hyperventilate patient, what happens to these waves? When you if there is a raised ICP and you are hyperventilating, so you're buying some time, so your P2 goes down.
P2 goes up.
And your P3 also goes down, but P1 remains same. So they might show certain scenarios and and they'll ask you to interpret. So if P2 is bigger than P1, ideally P1 should be bigger, but if then it indicates reduced compliance. And in next slide they will show the P2 P3 has normalized. So what they have done, maybe they have taken measures to reduce the ICP or increase the compliance. So like maybe they have given the osmotherapy, they have done hyperventilation, and if they have increased MAP, then P1 should go up, P2 P3 will decrease and P1 will go up provided your autoregulation is maintained. So you need to know these waves so that you can interpret. There is no need to remember all these things. So again, in this is the spotter. In CBS, they will keep this. In first slide, P1, P2, 3, P2, 3, P2, P3. You can see all the three waves in amplitude, all are increased. All waves are increased in the amplitude, x-axis, y-axis, as compared to that. So you can see that there is an increase in CSF volume if the amplitude is increased. If all the wave amplitude is decreased, you can say there is a decrease in CSF volume. So that can happen if you are draining through EVD, large volume. And the shape will not change. P1 will be still higher than P2, P3. The height of all the three waves, amplitude will decrease. Or even the reduced amplitude can be there with the missing bone flap when they remove the bone, then also. And prominent P1, as I have said, when systolic BP is too high, then your P1 will only increase, P2, P3 will be at the same level. When P1 is reduced and P2, P3 is at the same level, it indicates there is a very low BP. And when that's why there are targets to maintain this blood pressure in traumatic brain injury. If your P1 goes down below P2, it means again P2 will look equal to P1 or P2 will look bigger than P1. That is detrimental. And prominent P2, again loss of compliance we have seen. Diminished P2, P3, hyperventilation. Your P1 is not changed, but P2, P3 has decreased, means you are hyperventilating. And this rounded form of this, it is very high. This last slide, you cannot make out the waves. It looks like an arterial trace, rounded form. It shows like plateau waves, plateau A waves. It's a very critically high CVP. So looking at this CVP waveforms, you can make out. In the same graph, you need to know this. I have mentioned similar things in these slides. Now again, this you can make out this. There are two ICP values, at ICP at 15 and ICP at 50. So when ICP has 1.5, you can see nice sinusoidal. There are multiple waves, but you can make out the sinusoidal pattern. Like there are variations with the respiration. So these are B waves, and because again A, B, C, you need to know. A are pathological plateau waves. It has a very high amplitude but the very low frequency. B will be between 2 to 10 frequency and amplitude, and C will be the smallest. So these are the B waves. If they have multiple variations with the respiration, they are associated with the respiration. So if there are multiple variations, means ICP is low. When the variability becomes less, it becomes flat. It indicates again high ICP. And again, these pathological A waves I have told you about. So when these very high amplitude, almost 50, 60, it indicates very pathologically high raised ICP. But again, generally they last for 15, 20 minutes and then they come down. So it indicates there was something that has increased the cerebral blood flow, blood volume, and that has raised his ICP transiently for some time. But autoregulation is intact. That's why it has come down even to normal or below normal. But if these waves remain there for more than 20 minutes, 30 minutes, then definitely it's very, it indicates that it's critically high ICP is there and you might need to decompress. So I have already mentioned this invasive, non-invasive method. You need to go through this because in spotters, why I've included this in the theory, because in spotters definitely one of these will come. Again, now the post-decompression craniectomy on day 4 of the ICU stay. Despite ox sedation for more than 24 hours, patient GCS was E1 M1 BT. So EEG was planned, and it shows like this is the strip of that EEG. Can anybody interpret it and what it indicates? You need not know all the EEGs, but the basic waves, what A, B, theta, delta, they look like, what are left-sided, right-sided montages, various channels. So you need to know certain patterns also. So this is a very classic pattern. Can anybody tell me what is this? There is a background, no activity, and then suddenly, huh?
Isoelectric ECG, ma'am.
Isoelectric, no, but there are bursts also. No, in between there are a lot of spikes. There is
Also, sir.
isoelectric. Yes,
Burst suppression.
yes. So this indicates burst suppression. Again, there are certain malignant EEG patterns, especially post cardiac arrest. Also, we many times for neuroprognostication we do EEG. So burst suppression you achieve for status epilepticus. You achieve this pattern to like avoid brain damage from the continuous status seizures. So you aim for this pattern, burst suppression pattern, by giving sedatives. But here we have stopped sedatives. Everything is nothing is ongoing. The patient is not waking up. That's why we have done this EEG. So this EEG indicates poor prognosis. Like patient's brain activity is bare minimum. Isoelectric EEG again it indicates brain death. And even this burst suppression is patient is heading towards cerebral circulatory shock. So again, this was the EEG pattern for further prognostication and further management. We repeated CT scan. It showed gross cerebral edema with uncal herniation. And then now, because patient's status is even M1BT and people is not reacting, EEG is showing burst suppression. Repeat CT scan is showing irreversible brain damage. So we thought of checking his brainstem function. So generally, when you go for testing for a brainstem, for most of the cases,
And generally, we go for brainstem when patient is comatose, ruling out all the confounders like drugs, intoxications, and hypothermia, and then electrolyte and acid-base balance. It all are normal, and still patient is comatose. Patient has no respiratory effort. Then we will have to rule out brain death by checking the brainstem reflex.
yes, but the very important word is irreversible cessation of all these activities, brain activities, irreversible, or there is a irreversible cause for his coma, and that is for that you need neuroimaging. So irreversible coma cause on neuroimaging if it is showing severe brain damage, uh, like maybe massive hemorrhages, midline shifts. In our case, gross edema with uncal herniation. So when there is a irreversible cause, there is no point of return. Uh, it's there, or maybe hypoxic brain damage. You have MRI showing multiple watershed infarcts. So these are the patterns which are showing irreversible cause of his unconsciousness. And of course, then you have ruled out the confounders, and there is an irreversible cause of unconsciousness, and patient is completely ventilator bound. He's not maybe not triggering and all that time. Especially, it takes like 4 to 6 hours. If there is a now in our case, it's a massive road traffic accident, young boy, non-compliant brain because brain is not atrophic, and we have all signs of raised ICP and impending herniation, and this irreversible CT scan. So you observe for 4 to 6 hours most of the times, and then you go for brainstem checking. When it is a cardiac arrest situation, then you have to observe little longer. And if you are doing therapeutic hypothermia post ROSC, then you have to wait little longer, 24 hours post rewarming. Then you can check for the brainstem function. Otherwise, if there is a irreversible cause, like in this case, after 4 to 6 hours, you can go for brainstem function testing. And you rightly said prerequisites: patient should be normothermic beyond more than 36.5. There should not be any sedatives. There should not be muscle relaxants. Patient should not have influence of muscle relaxation. There should not be any metabolic derangements, hypernatremia, or any endocrine problems, severe hypothyroidism. And even if the patient is, we don't know the drug history. Most of the times we like, if we know the drug history, then you have to wait for 5 times the half life of that drug, because in 5 half lives, drug will be completely eliminated from the body. If the muscle relaxants were used, then you have to check for the train of force to see whether patient is completely out of muscle relaxant effect. So all these confounders you need to rule out, and then you have to go for the if you have checked this, you have to see the um, irreversible unconsciousness, apnea, and absent brainstem reflexes. I'll not go details into it of that, but you need to know how to do it. There are certain caveats where you cannot do brainstem reflexes, like if the patient's in head trauma, if the facial trauma is also there, then you and if there is a eye orbital injuries, you cannot check pupillary reflexes. You cannot do caloric test if there is a tympanic membrane rupture, or you cannot do oculocephalic when there is a cervical spine that is involved, Dolzai movement. So in such cases, when you cannot do your conventional brainstem checking, you have to do ancillary test. You cannot do apnea test directly. You can do apnea test only when your brainstem reflexes you find out that these reflexes are absent. So how do you do apnea test? Anyone quickly? Last few slides. How do you do this apnea test?
After confirming normothermia, normal electrolyte, and SBP more than 90 mmHg, and we will pre-oxygenate the patient for 10 minutes with 100% oxygen and take the baseline ABG. Then we have to disconnect the ventilator, put a suction catheter, connect it with the oxygen, give a flow of 2 to 3 liters of oxygen, and then wait and then watch for CO2 rise for 10 minutes, and again repeat the ABG. If ABG shows rise of CO2 by 20 mmHg from the baseline or 60 mmHg, then it confirms apnea.
Yeah, very good. Few points we need to, like, when you do baseline ABG, why you do pre-oxygenation for 10 minutes? Because you want PaO2 of more than 200, and because you are buying time. When you are disconnecting, patient will not desaturate, because again, if the patient desaturates to 85% or low for more than 10 minutes or so, you have to abandon the procedure. Again, you have to keep systolic BP more than 100. If needed, you put vasopressors, but you have to keep it more than 100. If during the test arrhythmias occur, or systolic BP drops, uh, then also you need to abandon the procedure. And later on, you need to increase or add on some other vasopressors, and you need to do the test. And if at all you have equivocal results, your CO2 rise is not that much, but patient has tolerated the procedure, so instead of 10 minutes, you do next time 15 minutes or 20 minutes. If there, like, no desaturation, no hemodynamic instability, but your result is unequivocal, you can increase the time also. So funda behind this, why 10 minutes of apnea and all, because every 1 minute of apnea will increase CO2 by around 2. In initial 1 minute it increases by 3, but later on by 2. So in 10 minutes it increases by 20. So at least with that, if patient, by despite increasing PCO2 by 20 or going beyond 60, if patient is not, there is no chest movement, abdominal rise, no grunting and all, it means patient is not breathing, so you can consider apnea test positive. And when you declare death, again in apnea test they might give different scenarios. If the patient is COPD, so in COPD you cannot say that PCO2 more than 60. And normally also when you set the ventilator, you have to maintain euc apnea. You try to, when you are doing pre-oxygenation, you try to maintain your RR of 12, 13, depending upon what was the last PCO2, to keep euc apnea, and then you carry out this test. But in COPD, you check the rise should be more than 20 from the baseline. If patient is ARDS, you might do that test with PEEP ball, if the PEEP requirement is there. And there are certain things, like how much flow should be on the TPs. Why not higher flow? Because all these things, because you are giving it through catheter, uh, through endotracheal tube. If it's a smaller one, it will entrap the air and it might cause the pneumothorax, because there is no ventilation. You're just giving air inside. So all these things you need to read regarding brainstem death. Okay. When you declare patient is brain dead after like first apnea test, then what you'll do? Immediately after first apnea, will you declare?
No, ma'am. It requires two apnea tests 6 hours apart.
Yes. So when the second apnea test is positive, that is the timing. And I've already explained कि there are like we cannot carry out certain tests, brainstem test, and sometimes we cannot carry out apnea test also if especially high cervical spinal cord injury is there. So you know that high cervical spinal cord injury C2, C3, C4 is the diaphragm supply. When that is cut off, you cannot carry out this apnea test. So in such cases, you have to go for ancillary test. What are the ancillary tests?
Nuclear
Like
sensigram.
Huh?
EEG and then cerebral angio.
Okay.
Then transcranial Doppler and EEG.
Yes. Good. So digital subtraction angiography, CT angiogram. Now there is no need of DSA. It is the gold standard, but you can do CT angio. And what you will notice now, like in this case, so apnea test was terminated due to desaturation and arrhythmia. So now we have to depend on the ancillary test. So what is this image showing?
No arterial filling, ma'am, of the brain.
Yeah. So even in C image, you can see the neck vessels are visible, but the brain vessels are not. So intracranial vessels, there is no flow, and extracranial vessels, you can make out some flow. In CT scan, in that bilaterally there is a hyperdensity because there is a stasis of blood. Because of the blood is not moving. There is a stasis, and that's why these two hyperechoic lines is seen, and there is no sulci gyri separation. There is gross cerebral edema, and in B also we can see that neck vessels are filling, but the blood vessels, the brain vessels are, there is no blood flow. So this is the CT angio showing no blood flow in the intracranial vessels. And what is this? And what is the sign?
Empty bulb sensor.
Yes, this is empty bulb sign. Cerebral scintigraphy. Again, there is no radio uptake and in the brain, and that's why it looks like an empty bulb. Again, this is the EEG pattern. This is the EEG slowing. You can it's not totally isoelectric, but yes, it is heading towards isoelectric pattern. So this is also indicative of brainstem death. Again, this is the transcranial Doppler. Definitely, they will now because this neuro sonography is also many hospitals they are doing, and it's in European hospitals also. So they will show you one of the slides, and you need to interpret. So neurosonology, you need to read. This is the MCA TCD, and this is the flow. There is a systolic peak, and there is a diastolic reversal. Normally, there should be the flow should be uh, like in this figure A. Can you see the slide? Students, can you see this slide?
Yes, ma'am.
So this is the A is the upstroke is the systole.
Yes, ma'am.
There is a peak systolic BP, and the flat line, this is the diastolic BP. So this is the normal flow. In B figure, there is a systolic upflow and diastolic flow is reducing. It is going down. So in that ICP, whenever ICP is increasing, your systolic peak is there and diastolic BP starts dropping. And as ICP equals your diastolic BP, and diastolic BP means it's not systemic diastolic BP of the MCA. So all these MCA, ACA, PCA, they have the peak systolic and end diastolic blood pressures. MCA has the highest peak systolic and end diastolic, but that end diastolic is somewhere around 35 to 50. So when your ICP increases to diastolic BP, means when it becomes 35 to 50, that time you will get this C pattern. There is a complete straight line and very low diastolic blood pressure, and there is a systolic BP is maintained. In D figure, there is a reversal of diastolic. Now there is no this above the baseline. There is no flow in the diastole. Rather, it is a reverse. So this D is, there could be a reversal of the flow with a net for, but still there is a net forward flow. In E figure, you can see there is this systolic peak, and there is a diastolic equally reversed diastolic flow. So the net flow is not there. In figure D, diastolic reversal is there, but systolic flow is still high. So still there is some forward flow, some blood flow is happening through cerebral vessels. In figure E, the systole and diastole are equal and they are in opposite direction. So net flow is not there, zero net flow. In F, there is very short spikes of systole. That's it. And in G, there is no flow at all. So your E, F, and G, all these three graphs indicates cerebral circulatory arrest. You can label patient brain dead, but not just one TCD. You have to bilaterally you have to check, and of course you have to check the other like EEG and other ancillary tests also. But again, E, F, G are very much consistent with cerebral circulatory arrest. So they might show you these three graphs. So any of these three graphs, when they are shown, it indicates cerebral circulatory arrest. So despite decompressive craniotomy, patient became brain dead, and you as an intensivist have to think about him as a potential organ donor. How will you communicate with his already dejected relatives regarding organ donation? Because already patient is so young, 30-year-old. They have done the decompression craniotomy also. They have bear all the expenses. They have done ICP monitoring. Everything was done, but now the patient is no more, and you have to how you will convey, and then how when you will talk about organ donation, what is your strategy as an intensivist? Now from saving the patient, your focus is shifting towards saving the organs, but at the same time you need to communicate this to relatives. How you will do? Anybody? This is the last question.
Ma'am,
You can.
ma'am, we will preserve the organ with maintaining the map, and will give the hormone replacement therapy, as well as we will not directly go for this communication part. We will involve multiple disciplinary team, and we will also inform organ transplant unit for the counseling of the relatives regarding the organ donation.
Okay, but you have to utter certain things, like you have to be very compassionate to relatives about the patient's loss. You have to give them some time, because here you being intensivist, your goal is to maintain the organs. For that you need invasive hemodynamic monitoring lines, because here you know that once the brain is dead, there will be catecholamine surge and there will be hypertension, hypotension, because the from rostral to caudal, when the brain gets involved till medulla, it goes through various hemodynamic responses. And again, the posterior pituitary gets involved early, so patient will have DI, electrolyte imbalances, and everything. So of course you need to do the invasive lines, and by this time you must have done the invasive lines because patient was in shock. But if not done, so we need to do this. But before that, you have to convey relatives about, you have to empathize them with their loss. You have to politely take them to the room, and before breaking this bad news, uh, you need to involve ask primary, and as you said, multidisciplinary approach should be there. Treating physician, neurology, everybody should be there. Uh, in a very empathetic way, you have to break this news at the and give them some time to go through it. Immediately, you should not talk about organ donation, because if it's a cardiac circulatory arrest situation, then really you don't have much time. Even if they are going through so much of a grief, you have to tell them give them the option of organ donation little early. But here you can give them some time to uh, get accustomed to this bad news, and you have to give them this that by saving, I mean, he was so young and he could have liked to you have to know whether he what kind of a person he was. Is there any advance directive that whether he was willing to do organ donation, that through social workers and through their contact, you need to know this information through them, and then you can tell them that he as a person, he could definitely do much more than this. He can save more lives by uh, donating the organs. And but again, you have to give time for the relatives to go through the trauma, and then as a multidisciplinary team, you have to tell them the positive sides of what his organs can do to so many people's lives. And then you can go for but meanwhile, again, being intensive, meanwhile you have to continue protecting all the organs. So though patient is dead, you have to feed the patient, you have to uh, monitor his urine output, you have to monitor his vitals. So your role doesn't end at the death of the patient. So this is a very extensive topic. I don't know, many of these things might not have made any sense, but you have to go through neurocritical care monitoring part, because this is very upcoming. It will come in your CCS, it will come in your CPS, and in some time it will be a part of neuro critical care management in our ICUs also. This is the just last slide. I have like post
Ma'am, are we
graduate.
going to have exclusive class on?
Uh,
Hello,
yeah, tell me.
ma'am. Are we going to have exclusive class on traumatic brain injury and neuro monitoring, or this was the class? Since means I was not expecting that entire traumatic brain injury and neuro monitoring will be discussed today only.
Yeah, actually, my class was brain death and organ donation. But for that to happen, they will generally give these scenarios, either RTA, road traffic accident, or maybe some poisoning, hanging, and there is irreversible brain damage. And then you're in EDIC, there won't be only one topic they will discuss. They will take you through different scenarios. The brain death will be the last two vignettes, won't be, or maybe when there is a or transplant related case, when there is a liver transplant, kidney transplant, then it might start with you have done the brain stems testing and then preserving. But generally they don't go for organ donation or the brain death as a complete case. That will be the last one or two vignettes. That's why I was like, I was not understanding how to incorporate it. But if needed, if you have any queries, I might like do it some other time. But overall, for traumatic brain injury, as I said, it's a very I mean, see, neuro cases, cardiac cases, this lung ARDS, pneumonias. There are certain things repeatedly after 2 3 years. They are maybe different case scenarios, but these are the common topics: road traffic accident, spinal cord injury, spinal cord transactions, autonomic dysreflexias because of that. These various areas of the brain, various herniations. So these are very common topics. After every 2 3 years, these games will definitely come, and you need to know all these things, all the targets, or you need to know the ATLS guidelines, Brain Trauma Foundation. important trials. I have not covered many things in this. Like if the hypothermia has any role, that is eutherm trial, rescue ICP trial, DECRA trial, even decompression cranectomy. So what is the outcome? Mortality benefit, but with dependency. So all these things you need to know because it's there out since 2020. The guidelines are out. Uh, the certain numbers when to do thoracotomy and all. You need to know all these things. Coagulation, even the rotem. If needed, as a spotter, I'll again take imaging and rotem. But I thought maybe I have mixed CCS and CBS in this. It's the brain death per se. It won't be a separate thing. It will be the last 1 or 2 minutes. Yeah. So I'll end session here, and it's just one of the things because in such images also might be there in the CBS, the C image C, where the decompression cranectomy was done, and now there the brain is sunken inside. It is called as a sunken flap or a syndrome of Triffine. So it happens when you don't do cranioplasty early, and it's not a good thing because it will damage your cognitive function and a brain's recovery will be delayed. So doing cranioplasty after decompression cranectomy is also important. Okay, then we'll end today's session. And sorry for this technical glitch. I will sort. I might need to buy new computer, अपना PC.
Okay, thank you for such an exclusive